schizophrenia spectrum disorder and eating disorders. So we are covering in today's talk two topics, that is Unit 5 and Unit 7. So what we are going to discuss in these two topics, we'll discuss about the introduction, what are the positive symptoms of schizophrenia, negative symptoms, disorganized symptoms, types of schizophrenia, other psychotic disorders, what are the etiology or causes of schizophrenia or psychotic disorders, and what are the treatment available for these disorders. And then in second part, we will be discussing about the eating disorders. So, what is schizophrenia? So, it affects individuals' cognitive and emotional functioning, including delusions, hallucinations, disorganized speech, behavior, and inappropriate emotions. The hallmark of the condition is break from the reality and withdrawal into their own world of delusions and hallucinations. It is characterized by disorders of thinking or disordered thinking. Thoughts are not logically related, faulty perception and attention, disturbed emotions, lack of emotional expressiveness or inappropriate emotions, and disturbed behavior, and disturbances in movement, uh, and lack of self-care, ill-kept. It affects nearly 1% of the population, around if you include schizophrenia and all other psychotic disorders. Then it usually begins in adolescence and early adulthood. About 50% have comorbid substance abuse. So schizophrenia is a type of psychotic disorder, and there is a high suicidal rate in schizophrenia, often face discrimination and marginalization by the society, and most of the patients earlier they were abandoned by their family because it is very difficult for the family to manage such patients. Let us see the different DSM criteria for diagnosing schizophrenia spectrum disorders. So they are given in A, B, C, D, E, F. So under A, two or more of the following, or at least a 1 month period of time, and at least one of them must be 1, 2, or delusion, hallucination, disorganized speech, grossly disorganized or catatonic behavior, or negative symptoms such as diminished emotional expressions. So there must be delusion or hallucinations. B. Social occupational dysfunction, impairment in one of the major area of functioning for a significant period of time since the onset of the disturbance, like work, interpersonal relations, or self-care, or study, academic performance. Duration. Some sign of the disorder must last for a continuous period of at least 6 months. So if the period is less than 6 months, then we have to diagnose some other disorder, not schizophrenia. So D, schizoaffective and major mood disorders exclusion. Schizoaffective disorder and bipolar or depressive disorders with psychotic features have been ruled out. Then only you can diagnose schizophrenia. Substance or general medical condition exclusion. The effect of a substance or another medical condition do not cause the disturbance. If the hallucinations are due to substance use, so there won't be diagnosis of schizophrenia. Relationship to global developmental delay or autism spectrum disorder. So if there is a history of autism spectrum disorder or a communication disorder, childhood onset, the diagnosis of schizophrenia is only made if prominent delusions or hallucinations along with other symptoms are present for at least 1 month. So generally, all the symptoms of schizophrenia can be divided into positive and negative symptoms. So under positive symptoms, delusions and hallucinations are the main symptoms. So let us see what is delusion. So delusion is a firm belief which cannot be interpreted or understood on the basis of patients or person's socio-economic educational background, and the belief is morbid in nature. So there are four qualities of delusion. First, false belief. Second, it must be firm or unshakable. Whatever evidence you can give, the patient is not going to accept those evidences. And the belief which cannot be understood on the basis of patient's socio-cultural educational background. And fourth, it is morbid in nature. Means when the person is having belief, he has to act out on those beliefs. He will just not that keep the belief in his mind. He has to act on those beliefs. So if these four qualities are there, this can be considered as delusions. So hallucination is basically hallucination come under perception. So keep this in mind. Delusions are part of thinking, and hallucinations are part of perception. So do not mix these both things. Though these both symptoms come together or seen together in the patient, it doesn't mean they are having same property. So delusions are basically distorted thinking, whereas hallucinations are distorted perceptions, or you can say that perception without any stimulus is hallucination. So let us see the types of delusion. There could be persecutory delusion. Under this, the patient may think that others are going to harm him, including family members. Okay. Control delusions. Patient think that someone is controlling the person's thinking and all other things. Grandiose delusion. Generally, it is seen in many mania. Like the person thinks he has too much ability, power, and he knows the big personality or celebrities in the world, and they are in close contact with him, and he has lots of money. Somatic delusions patient generally seen in schizophrenia and psychotic depression also. The patient thinks that the body parts or internal body parts are not there, or they are ruined, and like the skull is there, the brain is not there inside the uh, skull. So it is like a nihilistic. One of the example of such type of delusion is a nihilistic delusion. Ideas of reference. This is not delusion where, and there is a difference between ideas and delusion. In ideas, it could be false, firm, and it may also be not able to understand on the basis of socio-cultural educational background, but there may not be acting out or morbidity. So in a referential delusion, the person thinks everything is in the reference of or in context of himself. Let us see the hallucinations. As I told you, hallucinations are the perception without any stimulus. So there is no stimulus, and person may hear certain voices, person may see certain things. Okay, where there is a difference between hallucination and illusion. Illusions are not pathological; they are more or less universal, and some illusions are individual also. For example, like in uh, illusion when you are in a train, running train, so you may see that the trees are moving. Okay, so this is illusion, and everyone may have such type of illusion. But hallucination is pathological. It is seen in psychotic disorders only, not in normal persons. So there are different types of hallucinations because we have different sensory modalities: auditory hallucination, visual hallucination, olfactory hallucination means the person may smell certain gas or something. Tactile hallucinations, person may feel something is touching his skin or body. Gustatory hallucinations, person may have certain different taste, poisonous taste of his food. So person may think that the family members had mixed poison in his food. So in psychiatric disorders, generally auditory hallucinations are mainly most commonly seen, though there are other hallucinations also. But if the person is having only visual hallucinations, no other hallucinations are there, and delusion maybe they may not be there. So just presence of visual hallucination is may not be indicative of psychosis. It may be indicative of some neurological disorder or brain tumor. Coming to negative symptoms. So, what are the negative symptoms? Evolution. So, lack of motivation and seeming absence of will, interest in the ability to persist in routine activities, alogia, significant reduction in the amount of speech, delayed or slow comments, and hedonia, loss of interest and experience of reported pleasure in activities. So, like the person do not feel like doing anything, do not feel like talking, and unable to enjoy the pleasurable activities. Or sociality, like severe impairment in social relationship, the person remains aloof, doesn't want to interact with others, flat affect, lack of outward expression of emotion. Like when we are talking about something good, so there will be there will be smile, or anyone can make out that I'm talking something good. And when we are feeling sad, person may ask us, "Hey, what happened? Why you are looking sad?" So it means we are expressing our emotions. But when the person develops schizophrenia and having negative symptoms like flat affect, so the person may not have any expressions of emotions. So the facial expression looks blunt. There won't be any expression. So you can't make out the person is happy or sad. Then disorganized speech, affect, and behavior. You cannot make out anything from the speech of the person. It will be very difficult to understand. Then certain thought disturbances. So there are four types of thought disturbances. Disturbances in content of the thought, that like presence of ideas or delusions, and form of the thought. So disorganized thinking speech is disturbance. Like there is a formal thought disorder. We'll discuss later on also. And flow and stream of thought. So here we see the circumstantiality. Like when you ask something, so patient will give answer, but before giving the answer, the person will give lots of trivial details, which is not required. But ultimately, the person gives the answer. Possession of thoughts. Generally, thought alienation seen in schizophrenia. The patient believes that someone has inserted thoughts into his mind, and whatever thoughts are there, they are not his own thoughts. So, problems in organizing ideas and speaking so that the listener can understand. So, it's very difficult if the disorganized symptoms are there in the schizophrenia, you can't understand the speech. So as I told you, under formal thought disorder, derailment or loose association between different sentences, the person is talking on one topic and all of a sudden derail from that topic and starts another topic. Neologism. Neologism means coining new words or giving new meaning to the old words. For example, any words which we have not heard, the patient may find. And if you ask what is the meaning of that word, patient may try to explain also. And sometimes this is also possible that whatever words are existing, for example, mobile. So if patient is saying mobile, but if you ask you what is mobile, so patient may explain it in a different manner. So it is not mobile. Now the person is using the word mobile. Clang associations are basically repetitions of the same words over and over. So speak in a manner that the words rhyme. So generally it is seen in the manic disorder also. Then disorganized behavior, people lose their ability to organize their behavior to make it conform to social standards. Conform to social standards means it will be very difficult for them to follow the social norms. Catatonia or motor dysfunctions. Catatonia, what is catatonia? Catatonia is inability to move limbs, or the patient maintain the postures, and patient remain in that posture for longer period of time, which is not possible for the normal person to maintain that much longer period of time, that picture, that posture. Disorganized affect, like difficulty in organizing emotions to suit to the need of the situation. That's why you may be knowing that sometimes where the scene is sorrow, like someone has died, the patient may be laughing. So they're totally contrast. So the emotions are not in the relation with the situation. Like other symptoms may also present: echolalia, echopraxia. Echolalia is basically copying the uh, speed. So whatever you are telling, patient may repeat. The same way the person may repeat the action of the person. So let us see what are the different types of the schizophrenia. So paranoid schizophrenia is most commonly seen type of the schizophrenia. Presence of delusion and or hallucinations. Additionally, disorganized speech affect catatonia, or disorganized behavior will not be there, or if they are there, they are not prominent. So the main thing in paranoid schizophrenia is delusions or hallucination or both. Usually the person is black with the persecutory delusions, and delusion of grandeur may also be common. Like both the delusions, persecutory delusions, like people may harm him, or a grandiose delusion, like he has in lots of power, energy, or he is very popular person. And lack of insight, and the person is not able to take critical judgment and may display erratic behavior. Erratic behavior means the behavior which you can't predict, like when the you cannot predict कि now the person will react properly or angrily. In disorganized schizophrenia, generally the symptoms are disorganized speech, disorganized behavior, flat or inappropriate affect. Criteria for catatonia will not be there. If it is there, then we have to make the diagnosis of catatonia, catatonic disorder, or catatonic schizophrenia. So this disorganized schizophrenia was earlier called as hepiphrenia. Usually, it has an early insidious onset. Early means generally in early childhood, early adolescent stage. Insidious onset means slow. Slowly, the symptoms starts. Not all of sudden, all the symptoms start. It may take years to develop full-fledged symptoms. So usually it has an early insidious onset, and this is less common. It is not very common type of schizophrenia, and it represents more severe disintegration of the personality, and that's why the prognosis is also poor. The person is likely to have a history of odd or eccentric behavior, and early signs generally seclusion. So the person may not be very interactive with the family members, or may not be very social type of person. Coming to the catatonic schizophrenia, so motor disturbances are predominant. As I told you, the patient maintains postures for longer period of time, which is not possible for the normal person. Display flexibility and maintain limb and body positions for a long duration of time, and on other occasions engage in excessive activities. Mutism may be there, and word repetition and movement imitations may be there. Passive flexibility is basically movement imitation, the type of movement you do patient may, and the movement will be like uh, flexi flexibility. There is another type which is called the undifferentiated type. So if there are symptoms of the schizophrenia, but there is it is difficult to decide which category it is. So this is the undifferentiated type of schizophrenia. Another one is a residual type. So people who have had at least one episode of schizophrenia but may not uh, have any longer major symptoms. So one episode but may not have major symptoms. They may show residual or leftover symptoms such as unusual ideas that are not fully delusional, and may show social withdrawal, flat affect, activity, and odd thoughts. So, if the person is recovered to some extent, but still residual symptoms are there, we can diagnose the person as residual schizophrenia. Let us see what are the other psychotic disorders. So, apart from schizophrenia, there are other types of psychotic disorders also called schizophreniform disorder, schizoaffective disorder, delusional disorder, brief psychotic disorders. So, let us see in brief what are these types of disorders. Schizophreniform disorder. So, my experience of symptoms of schizophrenia for a brief period of time in life can usually function more or less normally after the episode, and the reasons are not very clear. So the criteria are two of the following: each present for a significant portion of the time during a 1 month period. Delusions or hallucinations, disorganized speech, grossly disorganized or catatonic behavior, negative symptoms that is flat affect, alogia, or an episode of disorder lasts at least 1 month but less than 6 months. So see, 6 months, if the symptoms last for 6 months, then you can make the diagnosis of schizophrenia. But if the duration is not fulfilled, the patient does not have symptoms for 6 months, so then you cannot diagnose it schizophrenia. So there, then the diagnosis is schizophreniform disorder. So schizoaffective disorder and depressive or bipolar disorder with psychotic features to be ruled out before diagnosing this disorder, and the disturbances is not attributable to the physiological effects of a substance or any other medical condition. So all these sorts of symptoms can be seen in a person who is having certain medical condition, neurological condition, or substance use. So you have to take the history carefully. Coming to schizoaffective disorder, so experience both schizophrenia symptoms and mood disorder symptoms. So here schizoaffective. Schizo means symptoms of schizophrenia. Affective means symptoms of affective emotions or bipolar disorders. The prognosis of this condition is poor, and an individual experiences both psychotic symptoms and mood symptoms. Psychotic features are present for at least 2 or more weeks in the absence of a major mood episodes. This condition is further divided into bipolar or depressive type. DSM-5 criteria for schizoaffective disorders. So, an uninterrupted period of illness during which, at some time, there is either a major depressive episode, a manic episode, or a mixed episode concurrent with symptoms that meet criteria A for schizophrenia. So, remember, let me go back to the slide where criteria A is there. So this is A. Remember this A. Two or more of the following, or at least a 1 month period of time, and at least one of them must be one or two. Okay. So these criteria you have to remember before diagnosing anything. Okay. Then during the same period of illness, there have been delusions or hallucinations for at least 2 weeks in the absence of prominent mood symptoms. If prominent mood symptoms are there, then the diagnosis could be by BPAD, bipolar affective disorder, or depressive disorders with psychotic symptoms, or manic episode. Symptoms that meet criteria for a mood episode are present for a substantial portion of the total duration of the active and residuous period of the illness. The disturbances is not due to the direct physiological effect of a substance or a general medical or neurological condition. Coming to delusional disorder. Delusional disorder is a psychotic disorder. Individual has rigid and persistent belief that does not correspond to the reality. It does not share any other features with schizophrenia except the presence of delusion. So remember, in delusional disorder, there won't be any schizophrenia symptoms except delusion. So only one symptom will be there, that symptom is delusion, nothing else. So if only delusions are there, no other symptoms, so we make the diagnosis of delusional disorder. Speech and behavior do not show the gross disorganization or deterioration. And generally, the delusions are what? The mainly delusion is related to infidelity. They suspect the fidelity of their partner. They, they believe that they have delusion that their partner is not faithful. So for that, they do lots of things. So delusion of infidelity, persecutory delusion, like people are trying to harming him, erotomania, like everyone is loving him or her, jealous type of delusion, and somatic type or mixed type of delusions. So let us see the DSM-5 criteria for delusional disorder. The presence of one delusions with a duration of 1 month or longer. So at least one delusion should be there. Criteria A for schizophrenia has never been met. So if hallucinations and disorganized speech, other things are there, then you cannot diagnose delusional disorder. Apart from the impact of the delusion or its ramifications, functioning is not markedly impaired and behavior is not obviously bizarre or odd. So it will be very difficult for anyone to diagnose a person with delusional disorder because everything will be all right. You cannot make out with the talking with the person that he is having some problem until and unless the person share delusion with you. If manic or major depressive episodes have occurred, these have been brief relative to the duration of the delusional period. The disturbances is not attributable to the physiological effect of the substance or any other medical or neurological conditions. So delusional disorder means just one presence of one symptoms, that is delusion, nothing else. Coming to the brief psychotic disorder. So let us see what is brief psychotic disorder. Sudden onset of psychotic symptoms, disorganized speech or behavior. Episode lasts for a very few days, not enough to warrant a diagnosis of schizophrenia. So for diagnosing a schizophrenia, there must be 6 months of period. Whereas in a schizophrenic form disorder, at least 1 month. So here the symptoms does not last for that much period. The person usually returns to former level of functioning and may never have an episode ever again. So just one episode, brief episode of psychosis, having delusions or hallucinations or other things, disorganized speech or behavior, and after that the person becomes all right, and then the person may not have repetition of such symptoms in future. Some of them may have, some of them may not have. The episodes may be triggered by extreme stressful circumstances. So, what are the criteria? The presence of one of the following symptoms: delusion or hallucinations, disorganized speech, grossly disorganized or catatonic behavior. But remember, do not include a symptom if it is a culturally sanctioned response. Okay. So, duration of an episode of the disturbance is at least 1 day, but less than 1 month, with eventual full return of the premorbid level of the functioning. So, if The symptoms last for 6 months. You can diagnose that schizophrenia. If they last for more than a month, you can diagnose schizophrenic disorder. But if symptoms last than a month, then you can diagnose the symptoms as brief psychotic disorders. Let us see what are the etiology of the schizophrenia or different psychotic disorders. So we can divide it into two group: biological factors, biological causes, and psychosocial and cultural causes. Under biological causes, genetic factors we all know, and then family studies have already. There are some evidences that if parents are having schizophrenia, there is a possibility in that children developing schizophrenia. Twin studies also suggest such thing. Chromosomal defect has also been seen in schizophrenia. Prenatal exposure. There are three stages of pregnancy: prenatal, perinatal, and postnatal. Prenatal means before the delivery. So when the mother get pregnant, from there to before the delivery. Then certain viral infections and blood group RH incompatibility, they are responsible for schizophrenia. Pregnancy complications during birth and pregnancy. So any perinatal complications may lead to schizophrenia. Early nutritional deficiency and maternal stress, malnourishment, and neurodevelopmental factors like uh, if there are a lesion in the brain or there is a defect in the brain, so there is a possibility of developing schizophrenia. Neuroanatomical factors have also played a role, like brain volume, like different anatomy of the brain. Like after the patient died, the autopsy of the brain was done, and it was seen that the volume of the patients, those who are suffering from schizophrenia, is less than the normal person, and enlarged brain ventricles, so the tightness was not there. Specific brain areas is like the disturbances seen in temporal lobes, amygdala, hippocampus, and thalamus, and abnormally low activity in the frontal lobe, missing inhibitory interneurons. And neurochemical factors, dopamine hypothesis, we all know that the imbalance is found in the dopamine neurotransmitters. There are certain neuroanatomical factors also play a role. And when you do the neuropsychological assessment of the schizophrenic patients, you found that their performance is poorer on neuropsychological test. Any type of neuropsychological test you will give, their performance will be less, and their reaction time will be slow, and sustained attention will be poor, and there will be deficit in executive functioning also. So these are the biological factors. Coming to the psychosocial cultural factors. So familial environment, cold and aloof behavior of parents, and a particular mother leads to, like there was earlier hypothesis, according to Batson, schizophrenia was a result of being presented with ideas, feeling, and demands that were mutually incompatible, or they are contradicting each other. So now, so there was a time when the mothers were blamed for the schizophrenic child, but the recent studies showed there was no such thing found. The interpersonal relationship, highly emotional family environment can prove to be very stressful, and expressed emotions generally they are very responsible for the maintaining and the relapse of the schizophrenia. It is seen that critical comment by the family members on the patient, hostility towards the patient, and over involvement by the parents. This may lead to relapse, and urban living conditions may also play some roles. Immigration is we all know that it is a very stressful. We have to adapt in different society and culture. And the cannabis abuse is also seen associated with the hallucinations and developing delusions or anhedonia, evolution. All negative symptoms are associated with heavy cannabis use. So, what is heavy? It doesn't mean it is quantity. For a person, just one giant may be heavy. For another, three or four may not be heavy. But so no one knows. If you start taking cannabis and you will develop schizophrenic symptoms, then people will know that okay, it was heavy for you. So better keep away from such things. So there is a diathesis stress model of schizophrenia, like there is a genetic vulnerability and genetic influences the parental and prenatal and perinatal environmental stressors and brain vulnerability. So all these vulnerability will induce developmental maturational process and stress, and that may lead to psychosis. So let us see the symptoms of treatment of schizophrenia. So it can be divided into pharmacological and psychosocial. So there are different medicines available. Electroconvulsive therapy, where electric shock is given, and like there is a myth that it is very painful and dangerous, but the electroconvulsive therapy is given with anesthesia, so patient may not feel the pain. So there are different antipsychotic medicines. All these medicines are prescribed by psychiatrists, and the patient should take and family members should give the medicine as per the advice given by the psychiatrist. So it's very dangerous to change the dosage according to family members or patient's wish, or not to give, or all of a sudden give more medicine. All may affect negatively. So always, like you give the advice to the family members of the patient that whenever you think that the medicine should be changed or the doses should be reduced or increased, you must talk to your doctor rather than doing by it yourself. So, psychosocial treatment basically help the patient to gain insight. Supportive psychotherapy is very helpful, and but remember, therapeutic intervention cannot cure schizophrenia completely. So, if the patient is treated with medication and patient is doing well, having few symptoms, so you can plan your psychotherapy according to those symptoms. And rehabilitation is possible with the help of psychotherapies, including psychoeducation and behavioral techniques to teach social skills, self-care, and vocational skills to patients with schizophrenia admitted in hospitals. So, social skills, basic conversation, assertiveness, and relationship building. Money management also you can teach the patient. Psychoeducation of family members are very important. Coming to rehabilitation, so vocational training can be given if patient is having just negative symptoms or minor. Halfway home if patient cannot go and live with the family, so there are halfway homes where patient can stay in the night, go in the morning for job, work somewhere, and generally finding the job. Generally, the counselors or social workers, psychiatric social workers, they help the patient to finding the job. Coming to the next topic, eating disorders. Means the way we are eating, there is a problem. So we will be covering here bulimia nervosa, anorexia nervosa, and then etiology of eating disorder. Then we have to see the treatment. Let us see what is in eating disorders. So it is basically characterized by severe disturbances in weight concern. So all eating disorders are patients are having concern about their weight, and they are dissatisfied with their body, and they have eating problems. So they are concerned with weight, they are not satisfied with their body, and they are having disturbances in eating. Either they will eat more or less. So achievement of normal body weight through regular exercise and healthy eating is beneficial for our physical and mental health. So remember this thing, just dieting and other things, if it is not very supervised, it will be harmful. So the best way is to have normal body weight. We have to exercise and we have to eat healthy things. However, concern about body weight is somewhat more extreme in some people. They may engage in excessive dieting and rigorous exercise to lose weight, which in turn may lead to negative social, emotional, behavioral, and medical consequences for the individual. So let us see, there are three types. Individual eats minimal food and the body weights drop to the dangerously low level is anorexia nervosa. In bulimia nervosa, individual engages in episodes of binge eating and then indulges in self-induced ways of throwing the food out, like vomiting, use of laxatives, or other attempts. Binge eating, individuals binge repeatedly, but the episodes are not followed by compensatory mechanisms to throw out the body. So let us see in the all the types of eating disorder: bulimia nervosa, anorexia nervosa, and binge eating disorder. Under bulimia nervosa, purging type or non-purging type, and anorexia nervosa, restrictive type, and under binge eating disorder, binge eating person. Coming to bulimia nervosa. So the core feature of the bulimia nervosa is recurrent episode of binging followed by use of compensatory mechanism. Characteristic of a binge and purge episodes: eating much more rapidly than normal, eating until feeling uncomfortably full, eating large amount of food when not feeling physically hungry, eating alone because of feeling embarrassed by how much one is eating, feeling disgusted with oneself, depressed or very guilty afterwards, experience of lack of control, use of inappropriate compensatory mechanisms to prevent weight gain. So there are two types, binging and purging type, and induced vomiting, and binging and non-purging type. Other methods like laxatives, diuretics, NMN, etc. So here the non-purging type people take several medicines, whereas in first type the person tried to vomit. So there are criteria in DSM like recurrent episodes of binge eating, recurrent inappropriate compensatory behavior to prevent weight gain, then the binge eating and inappropriate compensatory behavior both occur at least once a week for 3 months, and self-evaluation is unduly influenced by body shape and weight. Binging or purging does not occur exclusively during episodes of behavior that would be common in those with anorexia nervosa. So see this diagram, the person goes for diet, try to control, then hunger, then anxiety, then the person eats a lot, then the person feels guilty, then again binge, numbness, first, then redemption. Then again, associated features of bulimia, eating disorders often exist with mood disorders. People with bulimia may have guilt, embarrassment, and vomiting, and the use of laxatives. Dehydration is also very common, and continued vomiting may lead to electrolyte imbalance. Coming to anorexia nervosa. So here the person does not want to eat because the person thinks that he may or she may gain weight. So people with anorexia are dangerously underweight relative uh, to their age, sex, developmental trajectory, and physical health. A reason is intense fear of gaining weight or becoming fit. Show disturbances in the way that experience their body. So for female, uh, the amenorrhea or the absence of at least three consecutive menstrual cycles. For male, diminished sexual appetite and lower testosterone levels. So subtypes of anorexia nervosa, restricting types, and binge eating or purging types, and atypical types. So intense fear of gaining weight, and anorexia usually begins in adolescence when an adolescent perceives self to be overweight. He or she then starts a diet that escalates into an obsession with thinness, and dramatic weight loss is achieved through restricted eating or by combining restricting with purging. So there are DSM-5 criteria. So restriction of energy intake relative to requirement leading to a significantly low body weight, then intense fear of gaining weight or becoming fat, and disturbances in the way in which one's body weight or shape is experienced, undue influence of body weight or shape or self-evaluation, or denial of the seriousness of the current low body weight. Then restricting subtype, like weight loss is accomplished exclusively through caloric restrictions and or excessive exercise, whereas binge eating subtype, the individual has binged or purged in last 3 months. So there are lots of associated features including anxiety, depression, substance use, OCD. Let us see the causes of eating disorder. So biological set point for weight is responsible for hunger drive, and that may lead to disturbances in neurotransmitters. So socio-cultural factors like media displaying idealistic body image of men and women, and their family influences. So like the type of body of men and women we see in TV, movies, social media. So it is like a very perfectly built body. So everyone tries to influence. And if there is a model in the family, then there is a big problem. Psychological factors like excessive focus on appearance and internalizing of thin idea, extent to which one associates thin with desirable, attractive, popular, and being happy, body dissatisfaction, dieting, negative affect, and perfectionism. So some OC trait may also be there. So let us see the treatment of eating disorder. So psychological treatments and drug treatments. So there is no evidence for the use of drug to treat this anorexia nervosa, and antidepressants are used by psychiatrists. So uh, the antidepressant, anti-anxiety drugs have shown some amount of anti-obsessional drug also shown some amount of uh, effect in the behavior. Whereas psychological treatment, like short-term cognitive behavioral therapies, are given. So CBT for bulimia teaches patients the physical consequences of binge eating and purging, and the ineffectiveness of vomiting and abusing laxatives for the weight control. So they are then advised to eat small portions of the food 5 to 6 times a day with at least a 3 hours gap between each portion to eliminate excessive fasting and consequent binging. Coping strategies for resisting impulse to binge and purge, and arranging activities. So CBT can be planned, and it has been seen effective. Some behavioral uh, techniques can also be uh, planned, like the reinforcing the behavior when the person follows the proper diet and when the person is having uh, less preoccupation with the weight or body figure. So let us see what we have studied today. So we have seen the schizophrenia. We have studied the schizophrenia. So let me summarize what we have studied in schizophrenia. We have seen what are the symptoms of the schizophrenia. So symptom under the symptoms we have seen the time duration for diagnosing different types of schizophrenia, and delusion and hallucinations, presence of delusion and hallucinations. Uh, so remember this thing as I have highlighted here also. Delusion is the disturbances of thinking, whereas hallucination is disturbances of perception. So thinking is separate than the perception. Do not mix these two things. That is one thing. Then hallucination and illusions are different, though they come under perception. So illusion is a more or less normal phenomena, whereas hallucination is a pathological phenomena. So we have to keep this in mind. If someone is having hallucination, it means the person is having some pathology. However, there are two types of hallucination called hypnagogic and hypnopompic hallucinations. They are they are very rarely occur in normal people, and they are fleetingly occur, like just for a brief few uh, fraction of second they occur and go. So they are not considered as pathological, and these hallucinations occur during the while we are going to bed or feeling asleep or at the time of getting up, like someone is calling our name. So what it is hallucination. But otherwise, all hallucinations are pathognomic of psychotic disorders. Hallucinations are not seen in any neurotype of disorders called anxiety disorder, depression, and OCD, somatoform disorder. No hallucinations, not hallucinations. Why? Because if there is a hallucination or if there is delusion, anything, either hallucination or delusion or both, the diagnosis should be psychotic disorders. You can't diagnose any other type of diagnosis. So, what are the psychotic disorder we have in second class learn? Right? Schizophrenia, bipolar affective disorders, they are under psychotic disorders. Why? Because they are having hallucinations and delusions. Then coming to the different etiology. So we have discussed about the biological factors which are responsible for development of the schizophrenia, and psychosocial factors which are also responsible for development of the schizophrenia. So there is a explanation which is diathesis stress model. So diathesis stress model says that we all have tendency to develop one or another type of disorders or illness. But when we will develop and what type of illness we will develop, it will be decided by our stressors. So, like in the same stressful situation, one person may become panic, another may develop generalized anxiety disorder, whereas another person may have psychosis, and another person may develop depression. So, same stressor, why there are different type of symptoms seen due to same stressor? Because that all the persons are different genetically, so the genes are different, their predisposition is different, they are vulnerable to different types of illnesses. So they will develop those illnesses only where for which they are prone. They will not develop other areas. So remember this thing. So we should try to manage our stress so there is a less possibility of developing any illnesses. Then we have discussed about the different types of schizophrenia, and the different types we have discussed about the paranoid schizophrenia, the most commonly seen, and there are other types of like disorganized schizophrenia, residual schizophrenia, catatonic schizophrenia. Then we have discussed about the treatment of schizophrenia. So under treatment, mainly biological treatment, pharmacological treatment with medication, with the ECT, electroconvulsive therapy, and psychosocial treatments are basically focusing on the rehabilitation and managing some residual symptoms with psychotherapy, and working with the family members, because if there is a schizophrenia, there is a lots of distress within in the family. So this is our job to manage the distress of the family. Then we have discussed about the eating disorders. Under eating disorders, we have discussed about the bulimia nervosa, anorexia nervosa. So under anorexia nervosa, the person is remain thin, and the person is too much preoccupied with the body safety. He should not get weight and gain weight. So there is a like the person will be dangerously underweight, and still the person think he is or she is all right. And there are different psychosocial interventions for anorexia nervosa and bulimia nervosa, which we have to like the CBT is the most commonly used, whereas behavior therapy in using reinforcement techniques can also be. So today we have discussed about the schizophrenia and psychotic disorders and eating disorders. In our next class, we are going to discuss about the somatoform disorders. So under somatoform disorder, we'll see about the what is somatoform disorder, what are the different criteria, what are the DSM-5 criteria to diagnose the somatoform disorders, what are the etiology, and how to manage the somatoform disorder. So then in somatoform disorders, like it is, we'll see the prevalence also, see how commonly it is present in our country, and we'll see there are different like to manage this somatoform disorder. There are different medications and different psychotherapies. So psychotherapies are very useful in managing somatoform disorders. Then in symptomatology, like we will also discuss about the earlier how it was diagnosed, like somatoform disorder, somatization disorder, or like the basically in other terms are like MUPS, medically unexplained somatic symptoms. Like the person may complain about the pain, lots of pain, but there won't be any physiological basis. The person may go for several investigations, but the findings will be normal. For example, the person will be having headache, severe headache, but MRI or CT scan will be normal. The person will be having severe abdomen pain, but the ultrasound, X-ray, CT scan will be normal. The person may feel too much weakness or may not feel like doing things, but the person is not having any physiological basis for that. The hemoglobin and other things will be normal. So all these things basically we'll discuss in our next class, and I hope you will come with reading the study material you must go through, and see. Thank you. Namaste.